Dr. Greg Poland, Professor of Medicine and Infectious Diseases at the Mayo Clinic in Rochester, Minnesota, and Director of the Mayo Vaccine Research Group. Much of the material that we'll be talking about today is part of an overall review paper that will appear in the Mayo Clinic Proceedings in the January 2010 issue. Pandemic H1N1 virus did appear in late March, early April, and we had the initial spring first wave. Now we are in the northern hemisphere in the second wave of the virus, and this second wave has been a moderately severe wave. We have thus far, mid-November 2009, had over 20,000 hospitalizations, over 4,000 deaths, over 120 to 150 deaths in children so far. By contrast, this time last year, there had been less than a total 100 deaths. So certainly this has been more severe than seasonal influenza generally is. But what's different is that this virus has primarily sickened younger children as opposed to older adults. It is the older children, however, that have been hospitalized. On average, about 25 per 100,000 are sick enough that they're being hospitalized. And yet it is the older adults that, if infected, have a higher death rate. It's a little bit confusing. So the infection rate is greater in young children, the hospitalization rate greater in sort of middle-aged children, if you will, from that 5 to 14 age period, but the death rate highest in older people who have underlying comorbidities. And that's pretty much been held true throughout this second wave. What we don't know sitting here today is whether we'll have a third or even fourth wave. In the 1957 pandemic, we had more than 4 waves that went out 2 to 3 years after the initial wave. So I don't think we've seen the end of this virus. It's possible that it could become more virulent. It has not mutated yet to date, but it has caused severe illness in people who have underlying risk factors. It's worth talking a bit about who those people are. Probably the biggest risk factor for hospitalization and death has been asthma. And a lot of physicians and even patients don't consider asthma a chronic condition. But in this case, it's not only a chronic condition, but a marked major risk factor for complicated illness and death due to H1N1. Pregnancy is another one of those factors. The first 18 women who had confirmed H1N1 infection in the U.S. who were pregnant, 6 of the 18 died. And that's been a sad story, but one that, again, we have to pay attention to. And similarly then, people with other underlying chronic medical conditions similar to seasonal influenza as risk factors. Heart disease, lung disease, diabetes. There have been 2 interesting groups, though, that have popped up this year that we've been relatively unaware of in terms of complicated illness due to influenza. Uniquely, perhaps, for this H1N1, we've seen 2 groups that we have to pay some special attention to, and that is people who are obese, particularly morbid obesity, and native peoples and minorities. At least in Canada, there is some evidence that the native peoples there have had more severe disease than the settler populations have. So that's a story whose end is not yet complete, and we still need more information. So one of the frustrating things for all of us is that as of mid-November 2009, a relatively small amount of H1N1 vaccine has been made available. About 45 million doses have been shipped so far of the close to 200 million that we may actually end up having. I think what we're going to see is a much enhanced vaccine supply in the December timeframe. Our fear is that people will look around, see that the second wave has started to wane, and say, well, why should I bother get the vaccine? But I can tell you, it is almost certain that we will have additional waves of the virus, and that this pandemic H1N1 strain will replace the seasonal H1N1 and will circulate again next year. So we really are trying to get across to people the idea that it's important to get their vaccine, if not for now, for a third wave or a seasonal wave next year, so that we boost people's immunity as high as possible. One of the things we often hear, and if you sit and look at the news stories, you sort of see the schizophrenia of it. On the one hand, groups claiming that shortcuts have been taken and it hasn't been tested and safe, and on the other hand, people screaming, where's the vaccine and what's taking so long? Well, the truth of the matter is this. This vaccine is being manufactured identically to the way seasonal vaccine is by the identical manufacturers in the same plants. We have 6 decades of experience of safety and efficacy in producing seasonal flu vaccines. And this process is absolutely identical. There are no shortcuts to take. That's why it's taking so long. If somebody wanted to make a shortcut, they couldn't. It just takes that long using chicken egg technology to make this vaccine. It takes so long because, after all, we are isolating the virus from mammals, from humans, and then adapting that virus to grow in eggs. It wasn't necessarily a very high growth strain that was used. That has been modified and improved. And then it's a lengthy process of developing the vaccine, testing it for sterility and purity, and then a variety of studies that were done to show that it was safe and immunogenic, meaning that it makes an antibody response. The vaccine has now been studied in prospective clinical trials in children, adults, and pregnant women, and found to be safe. Of the millions of doses that have been used so far, there have not been even one report of a vaccine-associated serious adverse event. Now, we expect that there will be some serious events that occur, but here's the difficulty. Temporality does not mean causality. Just because something happened within hours, days, or weeks of receiving the vaccine does not mean that it was caused by the vaccine. For example, of every 1 million pregnant women, 16,000 of them will have a spontaneous abortion within a 6-week time period. Well, by chance, there are going to be pregnant women who get an H1N1 vaccine, and by chance, within hours, days, or weeks, have a spontaneous abortion. It does not mean that the vaccine caused that, and that's a very difficult concept to get across, not only to the public, but to healthcare workers. So what I can tell you is the vaccine has been tested, and I should say it wasn't even required that it be tested, but the testing was done because of public concern. Another point worth making is that if this particular strain had been identified last November or December instead of April or May timeframe, we simply would have substituted this H1N1 pandemic strain for the H1N1 seasonal strain that goes into the vaccine. It would have been that simple. So people have a tendency to think that since this is a new or novel virus, they sort of associate that with exotic, and they begin to say, well, what do we know about this vaccine, and has this been tested? Again, 6 decades of safety and efficacy data with seasonal influenza vaccines. So what do we know so far? We know that the vaccine is effective in terms of raising an immune response, and to date, there have been no safety concerns. And I don't think we'll identify any significant safety concerns given how many doses have already been given. But let's lay the data out side by side. So let's say that you're an individual that says, well, I'm afraid of the vaccine. I'm going to take my chances with the virus. Well, the fact is that you have about a 30 to 50% chance of getting infected by the virus. And that has a number of implications. You might just feel miserable for a few days, lose a week of school or a week of work, or maybe not be able to attend a Thanksgiving or Christmas event with your family. Or you might have something more serious. If you're between the ages of 4 and 18, about 47 out of 100,000 of those kids are going to get sick enough that they're going to end up in the hospital. And for people that are ending up in the hospital, the first series out of Mexico, Canada, and California showed that between 11 and 17% of those individuals ended up dying. Again, that's not a minor illness. What's the risk from the vaccine? Well, so far the observed risk is 0. But if you decide, well, I don't want to take my chances with the disease, I want to get the vaccine. Well, your risk of getting infected, assuming that you're healthy enough to respond to the vaccine, is essentially zero. Your risk then of getting hospitalized is too small to be actually quantitated. What about the theoretical risk of the vaccine? Well, in 76, 77, the swine flu vaccine that was made then, and it was made in a different way than today's vaccine is made, led to an excess of Guillain-Barré cases of about 1 per 100,000 doses that were given. In 1992 to 93, and again in 93, 94, seasonal vaccines, made the way this current vaccine is made, were examined to see was there any excess risk of Guillain-Barré. In 92-93, somewhat under 100 million doses were given. There was no association with GBS. 93-94, they looked again, somewhat under 100 million doses, no association. When they combined both years so that they could look at a series of almost 200 million people, they could not exclude that there could be as high as 1 extra case of GBS per million doses given. So let's accept that as a background risk. So you have a choice here. Do I run a 40 to 20 out of 100,000 chance of getting hospitalized, and if so, dying, being sick, or a 1 in a million chance of something happening because of the vaccine? And I think that's the choice, that's a data-driven choice that people have to make. Because of the widespread illness, it's not possible to immunize everybody right now. It's not possible to treat everybody. It's not even possible to do diagnostic assays on everybody. But I think there are some groups that we would want to pay special attention to. Anybody who fits into a risk category, such as people with asthma, chronic lung, heart disease, pregnancy, young children under the age of 4, we would want to test them to see if they have pandemic influenza, primarily for the reason that if that test came back positive, we would treat somebody like that. Similarly, somebody in a long-term care setting or a hospitalized patient. But myself, for example, if I had flu-like symptoms compatible with H1N1, there's no particular reason to test me other than that I'm a healthcare worker, and no particular reason to treat me other than the fact that I'm a healthcare worker. The important piece about vaccinating pregnant women is the high mortality rate and complicated illness rate we've seen in pregnant women. And when you, as a pregnant woman, take the vaccine, you not only protect yourself, but you protect your infant once that infant is born. Certainly older people with underlying comorbidities are at increased risk of complications and death due to H1N1, but they are not at the highest risk of infection. So the decision was made that for this pandemic vaccine we would start with certain risk groups. Older people are not in that initial set of risk groups. By December timeframe, when we have a lot of vaccine, I think the indications will be expanded to those older age groups and eventually everybody to get H1N1 vaccine if they choose to get it.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.